When we intubate patients or place artificial airways, one of the major monitoring devices that we use is the capnograph. That's the CO2 trace in expiration, but also on inspiration. This is absolutely essential after the airway has been placed, but throughout the time that the airway is in situ, that capnograph trace can tell us all kinds of information. As an anesthesiologist or intensive care specialist, there are a series of abnormal capnographs that you need to be familiar with, and that's the content of this tutorial. I guarantee you'll learn something. Fundamentals of anesthesiology and critical care. With me, Pat Nelligan. Monitoring gases and vapors. Monitoring carbon dioxide. This is a series on capnography and capnometry, and this is part 3, abnormal capnographs. In the previous tutorials, we looked at monitoring carbon dioxide, and I explained mainstream, side stream, and microstream CO2 analysis, the normal capnograph, and the capnograph after intubation. For most healthcare practitioners, that's all you need to know. But I'm going to advance on this and go through a series of abnormal capnographs that you may encounter in your practice, particularly for anesthesiologists, and how to interpret them. And I'm also going to discuss what to look for if there is no CO2 trace after intubation. Let's start with a scenario. You're in the operating room. A patient has been apneic for a while due to difficult intubation, and you start mechanical ventilation. This is the CO2 trace. What's going on here? This trace demonstrates lung recruitment after commencement of mechanical ventilation. During apnea, there is widespread atelectasis and airway closure. When the ventilator starts, some lung units do not participate in ventilation but gradually open and release CO2. Let me illustrate this. Immediately after intubation, there is extensive atelectasis, low lung volumes, and airway closure. So these are atelectatic lung units, closed lung units, and partially inflated lung units. With early breaths, small areas of the lung are reasonably well ventilated, and the quantity of CO2 released is quite low, so the end tidal CO2 is low. With a couple more breaths, these lung units start to inflate better, so the end tidal CO2 increases, but much of the lung is still trapped behind closed airways and atelectasis. As ventilation progresses, closed airways are opened up as airway pressures equalize across the lungs and ventilation increases. Ultimately, all the ventilation perfusion problems resolve and the lungs ventilate well. The initial CO2 is quite high, but resist the urge to increase ventilation too much, as over a few minutes, the end tidal CO2 will normalize. All of this can be prevented by performing a recruitment maneuver. A recruitment maneuver or vital capacity breath, you can do this with a bag or better with the ventilator. There is a specific setting, 30 centimeters of water for 10 seconds in the operating room or 30 seconds in the ICU. So essentially you squeeze the bag and it pops open collapsed or closed airways and everything resolves very neatly. There is an elegant way of performing a recruitment maneuver on the GE ACES anesthetic machine. If you look at the screen and go down to the bottom right-hand corner, you will see a button that says Procedures. If you tap that button, a pop-up menu appears on the left-hand side of the screen. And amongst those 5 different options, there is an option for a vital capacity breath. If you tap that button, another pop-up screen appears. On the screen, you're offered two options for how to perform a recruitment maneuver. The first option is to set the pressure, in this case 30 centimeters of water. That seems reasonable. And the second option is to set the hold time, in this situation 10 seconds. When you're happy with the settings, push the button to start the vital capacity maneuver. The bag in the bottle ventilator will sink down, and then after 10 seconds will go back up again, and that's it. Inevitably, there will be an annoying large tidal volume alarm immediately afterwards that you can ignore. Let's move on to another clinical scenario. James is 25 and he's undergoing a knee arthroscopy under general anesthesia. He was given an opioid and propofol, and LMA was placed, and he starts to breathe on his own, and he's taking about 213 mils of tidal volume 12 times a minute. The end tidal CO2 starts at 25 millimeters of mercury or 3.3 kilopascals, and then starts to progressively increase despite no change in minute ventilation. What's going on here? This is the patient who is breathing spontaneously. Let's first look at the airway pressure trace, with positive pressure on expiration and negative pressure during inspiration. The trace looks like this. The patient is taking more or less the same depth of breath as evidenced by the negative airway pressure on inspiration throughout. Now let's overlay the CO2 trace, keeping in mind that they are not normally in sync on the monitor due to sampling delay. What's going on here? We have seen a similar trace before, and this is hypoventilation in the spontaneous breathing patient. Let me explain the mechanism of CO2 accumulation in this setting. In the first breath, the PaCO2 in the alveoli is normal. It's 40 millimeters of mercury or 5.1 to 5.3 kilopascals. But the dead space CO2 is relatively low. It's 20 millimeters of mercury or 2.6 kilopascals. By breath 30, the PaCO2 due to hypoventilation has built up in the alveoli, so it's up to 50 millimeters of mercury, about 6.6 kilopascals, and the dead space CO2 has increased also because of diffusion of that CO2 along the partial pressure gradient. So now it's up to 30 millimeters of mercury or 4 kilopascals. By breath 60, the partial pressure of CO2 in the alveoli is 60 millimeters of mercury. The dead space CO2 has increased quite substantially up to 50 millimeters of mercury or 6.5 kilopascals. And if hypoventilation persists at this level, the patient's PaCO2 will go up to 80 millimeters of mercury or about 10 kilopascals with a dead space CO2 of 70 or 9 kilopascals. If you decide to put James on the ventilator because the end tidal CO2 is too high, then the early breaths will deliver a higher end tidal CO2 than before, as alveolar PCO2 will now match end tidal CO2, but that will gradually fall downwards until a new steady state is achieved. Sometimes, maybe frequently in the operating room, you see this picture where the CO2 trace at steady state is very high. It's not getting bigger, thankfully, but it's not dropping. In the absence of the patient absorbing carbon dioxide, for example, during a long laparoscopic procedure, this is always caused by reduced alveolar ventilation, either due to inadequate tidal volumes or inadequate respiratory rate. It can also be due to excessive dead space due to too much PEEP, or an inadequate expiratory time due to a long inspiratory time with respect to the E time, or all of the above. Whatever way you look at this is hypoventilation. And I would like to make one point if you have a patient on a ventilator. For most people, the normal inspiratory time is 0.5 to 0.6 seconds. On someone on pressure support, it's 0.6 to 0.9 seconds. But most anesthesiologists continue to give their patients very long inspiratory times. An I/E ratio of 1 to 2 with PEEP is just too long. The traditional 1 to 2 I/E ratios did not use PEEP, and they used large tidal volumes. With these settings, the patient will have too high a mean airway pressure. So once steady state has been achieved during anesthesia with a high end tidal CO2, it is always consistent with a high PaCO2 and a low pH. It is very unclear if this is in any way harmful to patients, as millions of patients undergo intraoperative hypercarbia every year and wake up just fine. But if there is increased end tidal CO2 during mechanical ventilation, you should increase the minute ventilation to target a normal end tidal CO2. This may involve reducing PEEP or shortening the I to E ratio to reduce the mean airway pressure. For spontaneously breathing patients, you're probably giving too much anesthesia or opioids, but you should have a trigger number, maybe 60 millimeters of mercury or 8 kilopascals, for commencing pressure support ventilation to increase the tidal volume. Now let's move on. You intubate a patient yourself with a video laryngoscope. You see it passing through the vocal cords, the chest rises and the bag refills. And then you look at the CO2 trace after you put them on the ventilator. And you wait, and you wait, and nothing is happening. What's going on here? I previously showed you this image of an esophageal intubation and explained that you usually see a small amount of CO2 emanating from the upper GI tract. The absence of anything on the trace should open your mind. I want to draw your attention to another waveform that you likely ignore on the screen of the monitor or ICU ventilator, and that's the flow volume loop. As you can see in this situation, gas is flowing in and out of somewhere that looks remarkably like the lungs. In this case, there is not a CO2 trace, but there is a trace. Somebody forgot to attach the sample tube to the heat and moisture exchanger, so the analyzer is sampling room air. That is something that should always be considered if the end tidal is 0. There is perhaps nothing more embarrassing during the inevitable panic of a no CO2 trace than to peer at the heat and moisture exchanger and see this blue cap connected, meaning that the side stream analyzer tubing is not attached. Please don't humiliate your assistant. It is your responsibility to make sure that the equipment is working. But I want to make a point about flow volume loops. I think they're awesome. The flow volume loop is instantaneous and it appears 2 to 3 seconds before the end tidal CO2 trace. We are going to intubate a patient and put them straight on the ventilator. As soon as the first breath is delivered, you have a flow volume loop, but there is no CO2 trace. Just before the second breath, the CO2 trace appears for the first breath, followed by the flow volume loop of the second breath. Note that when the patient becomes apneic, the end tidal CO2 number stays displayed on the screen for at least 30 seconds while there are no flow or CO2 waveforms, and nothing changes until the apnea alarm goes off. 45 minutes into the case, you notice an anomaly in the CO2 trace. Can you spot the anomaly? The patient is on volume or pressure control on the anesthetic machine, and what's happened here is that they have a thing called a curare cleft. They're beginning to breathe spontaneously because the neuromuscular blockade has begun to wear off. But there is no assist control mode on the ventilator, so the patient is inspiring during expiration. This is easily explained on the flow waveform. The orange arrows are the mandatory ventilator breaths. The green arrows are the patient's unsupported spontaneous breaths. Sometimes they stack. Occasionally, you may see this picture where there are large breaths interspersed with smaller breaths. What's going on here? The same patient is now on SIMV, synchronized intermittent mandatory ventilation with pressure support, and the mandatory and assisted breaths are in orange, and they're interspersed with pressure support breaths in green. If the pressure support level is increased, all of these breaths may look the same. You give the patient some more muscle relaxants because the operation is going to go on for a couple more hours. And then you notice this particular trace. Now, what I want to draw your attention to is two things. First of all, clearly the end tidal CO2 is very high, it's 56. But there is another problem here, and that is this. The inspired CO2 is 8 millimeters of mercury. Perhaps this is more easily seen on this graphic. Note that the baseline is rising progressively. And when you see this, there is rebreathing of carbon dioxide. And this only really happens in the operating room when low flow anesthesia has been delivered, and it's caused by exhaustion of the soda lime during very long procedures, or the failure to replace the soda lime as it wears out. The soda lime is normally a creamy white color, and it turns dark purple as it starts to be consumed due to a chemical reaction with carbon dioxide. Now, let's move on to look at some abnormal capnographs. What do you think of this capnograph? What's going on here? In this situation, there is a terminal upstroke in the CO2 trace. A similar picture will be seen in the airway pressure trace. The sudden peak of pre-inspiratory expired CO2 is caused by abrupt airway closure. That last bit of gas is cut off. Sometimes this is called a phase 4 wave, and it is seen in patients who are morbidly obese or pregnant, and it's due to increased intra-abdominal pressure. What about this one? What's going on here? This is actually a normal capnograph. The distortion is due to a thrusting hyperdynamic heart causing oscillations during the exhalation phase. What about this one? What's going on here? Well, you can see that the upstroke here is very slanted. Normally, there's a little bit of an upstroke and then it goes up really quickly and flattens off, but it doesn't really plateau. Everything is just sloping upwards to the end of expiration and it falls down again. And this is due to slow emptying of different lung units with different time constants. And this is almost always associated with increased airway resistance, like you would see with COPD or with asthma. And I'm going to illustrate this. This is a patient with COPD. Although the alveoli are normal, there is a variable amount of obstruction within the airways. And that means that there are different time constants for each different type of airway in the lungs. The relatively unobstructed airways will empty first, followed by the next least obstructed, and so on and so forth, until the most obstructed airway empties last just prior to inhalation. And these are, as you can see, easily plotted onto the capnography curve. This will give you an idea of the rate of emptying of lung units along different time constants. Note that the highest concentration of CO2 in the lungs is at end expiration. This is a very unusual waveform. What do you think is going on? It's very strange because there is a very rapid upstroke in the CO2 trace and then it falls down a bit before it falls off a cliff. And this is a picture that you occasionally see in emphysema, and it is almost the opposite of what you see in bronchial obstruction. Some units empty rapidly and some empty slowly due to the loss of elastic recoil and airway collapse or closure. The initial exhale gas comes from very well ventilated units with higher CO2 concentration, but later in expiration gas comes from slowly emptying poorly ventilated units which may have a lower CO2 due to air trapping and incomplete mixing. This leads to the reverse slope as this concentration of CO2 decreases towards the end of respiration. And I'm going to try and illustrate this. In this model, there are two different types of lung units that I'm going to call fast and slow. Fast units are highly compliant, contain lots of carbon dioxide, and empty rapidly, faster than normal lung tissue. Slow units are poorly compliant, may be partially obstructed, and contain less CO2 and empty slowly compared to normal lung tissue. The highly compliant lung units empty really fast, resulting in a rapid upstroke of the CO2 curve. Very little of that CO2 lingers in the airway. There is delayed emptying of the poorly compliant and poorly ventilated lung units that empty slowly and deliver a lower load to the sampling device, resulting in a downward sloping curve. What do you think of this trace? What's going on here? This is what you see when there is an object or mass in the airway. There is obstructive flow in inspiration and expiration. Note how long it takes to transition from end expiration to inspiration. Now let's move on. You're doing an emergency case in the operating room. You intubate the patient, and 30 minutes later, you see this trace. What's going on here? This is absolutely the worst trace you can ever see on a patient in the operating room, the ED, or the ICU. There is an exponential decrease in the carbon dioxide that's coming back to the lungs per minute. And the reason for this is complete cardiovascular failure. There is a risk of imminent cardiac arrest. It might be caused by bleeding, it may be caused by acute right heart failure, it may be caused by pulmonary embolism. If you see this, you need to take note and assess the situation. Remember this trace of all of the traces that I have shown you. Now let's review this tutorial. This was the third tutorial on monitoring carbon dioxide that looked at some advanced capnograph traces. I showed you lots of traces that are abnormal, and I explained that if you have no trace on the capnograph but you have a flow volume loop, then there is a problem with your equipment, not a problem with your intubation or your patient. Then we looked at airway obstruction, emphysema, and ultimately impending cardiac arrest. In the next tutorial, we'll revisit the blood gas machine, and I will explain how that machine measures carbon dioxide and hydrogen ion activity. I'll see you then, and I guarantee you'll learn something.